histochemical stain. So in the lecture on AML, I had shown you one slide showing MPO positivity, myeloperoxidase positivity, that is seen in cells of myeloid lineage, okay, in AML. Whereas in case of ALL, the histochemical stain is PAS, and they have a typical block-like positivity. Can you see they are block-like positive? Okay, this is the typical block-like positivity of PAS in case of your ALL. This is very important. This is what you can expect in your exam slide. Okay, you will be given a peripheral blood smear. Okay, and can you appreciate over here what are these cells? What are all these cells? Yes.
Blasts.
Very good. They are the lymphoblast. Now, why am I saying is that it has a lymphoblast and not a myeloblast? Yes. Why we are saying that? Because if you see,
Coarse chromatin.
they have a high NC ratio. Yes. They have a coarse chromatin. Okay. Along with that, they have a scanty cytoplasm, scanty A granular cytoplasm, scanty A granular. Also, the nucleoli is inconspicuous, not that much present. Nucleoli is inconspicuous. Okay, so that is why we are calling it as this. And look, compare it with the size of a normal RBC. It is much, much bigger than the size of a normal RBC. So this is not a small lymphocyte also. So you tell me what is this and what is this and what is the difference? So this is basically a lymphoblast, okay? And this is a normal small lymphocyte in a peripheral blood. So let us see the point of difference between the two. Absolutely, the lymphoblast is larger in size as compared to a small lymphocyte. And you can see, how do you see the size of a small lymphocyte? The nucleus of which is absolutely, according to the size of a normal RBC. That is how we see the size of a small lymphocyte. If you look at the nuclear chromatin, if you now remember, both of them are having a high NC ratio. So you will say, sir, both of them are having a high NC ratio, then how do we differentiate? So one is the size. Lymphoblast, usually they are larger. Small lymphocytes are smaller in size. Second thing is that the nuclear chromatin, the chromatin is far more open, if you can appreciate over here, whereas the chromatin is far more coarser in case of small lymphocyte. Other thing, if you are going to see, there are certain nucleoli that is visible, 0 to 1 nucleoli. 0 to 1 nucleoli is seen, but over here, no nucleoli is seen. No nucleoli is seen. So it is imperative that you differentiate a lymphoblast from a small lymphocyte. Okay. Today's topic of discussion, we are going to start with acute lymphoblastic leukemia and lymphoma, and then we are going to discuss the remaining peripheral, myeloproliferative neoplasms that was remaining from the previous lecture. So let us begin with acute lymphoblastic leukemia or lymphoma. So before I start my class, can anyone tell me why have I used the term leukemia and why have I used the term oblique? I have used the term lymphoma. Can anyone tell me what is the meaning of leukemia? How leukemia is different from a lymphoma? Yes. Anyone? So whenever whenever there is an involvement of the blood, okay, whenever there's an involvement of the blood, we use the term acute lymphoblastic leukemia. In this case, the lymphoblasts are present in the blood, okay? So whenever your lymphoblast or any kind of blast, even your myeloblast, any blast, if it is present in the blood, we use the term leukemia. And when the lymphoblast or any other type of blast, it is involving the lymph node, we use the term lymphoma. So is this completely clear? Both leukemia and lymphoma, okay, both leukemia and lymphoma, they are the same manifestation of the same disease. Just in case of leukemia, there's an involvement of the blood, and in case of lymphoma, there is involvement of the lymph node. Is this clear to everyone? What is the difference between leukemia and lymphoma? Yes? Okay. So before I start with acute lymphoblastic lymphoma, you must understand few basic concepts, okay? Then only you are going to understand the concept of lymphoma or leukemia. So see, first of all, we are reading about acute lymphoblastic lymphoma today, okay? So in today's topic of discussion, we are going to mainly understand about acute lymphoblastic leukemia or lymphoma. So for that, we have to basically understand the growth and development of the lymphocytes. Okay, already we have done this diagram and already we have learned about the development. Just I'm going to revise few important concepts for understanding today's lecture. So for example, the B cell neoplasm, the maturation takes place in the bone marrow, whereas the T cells usually they mature in the thymus. Okay, so in the normal condition, if you see, basically the common lymphoid precursor gives rise to your precursor B cells. Okay, it gives rise to your precursor B cells. Okay, and from there we have the naive B cells. The naive B cells give rise to your cells of the mantle zone. Then they come into the germinal center, and finally they enter the marginal zone. So this is how normal development of B cells occur. I will just repeat. So B cells arise from common lymphoid precursors. Okay. Once they are arising from the common lymphoid precursors, they give rise to precursor B cell. They give rise to precursor B cell. That gives rise to naive B cell. Okay. From there, they come into the mantle cell zone. Then once they are stimulated by any kind of a virus or any kind of infection, they will enter the germinal center and they are going to proliferate, and they are then going to produce certain plasma cells which are going to produce antibodies. Okay. After that, finally, when their function is over, they will rest in the marginal zone, of the lymph node. So this is how a normal B cell functions. Now, tumor can arise or they can be arrest in the maturation of the B cell at any point. Okay. So in case of ALL, in case of acute lymphoblastic leukemia, the maturation arrest is taking place at this level. So what we have in the peripheral blood, we are having maturation arrest, and what we are going to see, we are only going to see the precursor B cell, that is the lymphoblasts. So tumor which is arising at this stage from these cells is called as precursor B lymphoblastic lymphoma or leukemia. We use the term lymphoma when it involves only the lymph node, and we use the term leukemia when it is involving the peripheral blood. Okay. Similarly, the T cells, okay, they also mature inside the thymus. First, they are double negative. Double negative means they are CD4 negative, they are CD8 negative. Then they become double positive. They have both markers positive, CD4 as well as CD8 positive. Finally, once they mature, they will either form CD4 plus T cells or they will form CD8 plus T cells. Okay. So if the tumor is arising from the precursor forms, any from over here, from the precursor cells, if the tumor is arising, if there is any maturation arrest at the precursor level, it is going to give rise to precursor T lymphoblastic lymphoma or leukemia. So acute lymphoblastic leukemia or lymphoma can be of two main types. Either it can be BALL if it is arising from precursor B cell, or it can be TALL if it is arising from the precursor T cells. Okay, so this is one important concept that we have to understand. Now you must be wondering what happens if the tumor is arising from the other parts. So for example, as I told you that from the precursor B cells, they are going to form naive B cell. So some tumors can arise from the naive B cell. They are called as CLL or SLL. Some of them can arise from the mantle cell called as mantle cell lymphoma. Some can arise from the germinal center like follicular lymphoma, Burkitt lymphoma, DLBCL, Hodgkin's lymphoma. Some can arise from the marginal zone, that is the marginal zone lymphomas. Even DLBCL, SLL and CLL can also arise from the marginal zone. All these tumors which are arising, okay, after the precursor, okay, they are called as peripheral B cell neoplasm. They are called as peripheral B cell neoplasm. Okay, similarly, all the neoplasm which is arising after the maturation of the precursor T cells, they are going to give rise to peripheral T cell lymphomas. Okay, is this clear to everyone? So there is a precursor B cell neoplasm, like over here, a precursor T cell neoplasm. The precursor B and T cell neoplasm, they are coming under the heading of acute lymphoblastic leukemia or lymphoma. Okay. So according to the current WHO classification, okay, if we have to, classify the lymphoid neoplasms, we can broadly classify them into 5 categories. The first and foremost, we separate them into NHL, non-Hodgkin's lymphoma, and Hodgkin's lymphoma. So There is one kind of lymphoma called as Hodgkin's lymphoma that is at one end of the spectrum, and at the other end we have rest of the lymphomas which comes under non-Hodgkin's lymphoma. Right now we had seen that the tumor which is arising from the precursor B cell is called as BAL, okay, acute lymphoblastic leukemia lymphoma arising from the precursor B cell. Also, we had seen the tumors arising from the precursor T cells, that is the neoplasm of immature T cells, give rise to TALL. Excuse me. That is your T acute lymphoblastic leukemia lymphoma. So today's topic of discussion, we are going to discuss this B and TALL. Apart from this, if the neoplasm is arising from mature B cell or mature T cell, then we use the term peripheral B or T cell neoplasm. So I hope you have understood how we classify the lymphoid neoplasms according to the latest edition of WHO. Okay. So let us start today without delaying acute lymphoblastic leukemia lymphoma, which is the arising from the cells of the precursor series. Okay. So first, very important thing, as you can understand, that acute lymphoblastic leukemia, they are neoplasms arising from immature or precursor cells. And if that is of the B series, we call it as precursor B lymphoblastic leukemia lymphoma. If it is arising from precursor T cells, we call it as precursor T acute lymphoblastic leukemia or lymphoma. Okay, so in any case, we can just refer to them as lymphoblast. Okay, as lymphoblast. Okay, now very, very important MCQ. Let us try and understand. Around 85%, of leukemias, I'm not talking about lymphomas, around 85% of all the acute lymphoblastic leukemias, they are B lineage, and they typically manifest as childhood acute leukemia. So remember, whenever we are speaking about acute lymphoblastic leukemia, you should always think that BALL is more common, okay, more common, and mainly they are involving children, childhood, okay, whereas the less common variety, that is the TALL, it tends to present in adolescent males, and mainly the most common presentation of TALL is as a lymphoma, as a lymphoma. They present as a thymic lymphoma, okay, they present as a thymic lymphoma, okay. So this is the TALL. Okay, so remember this point very importantly. Now, most lymphoblastic lymphoma, as I told you, when I'm speaking about lymphomas, not leukemias. Leukemias, mostly they are BALL. If I'm talking about lymphomas, then lymphomas are basically TALL. Okay, they are of precursor T cell lineage. Only around 15 to 20% cases of lymphomas, lymphoblastic lymphomas, they are of precursor B cells. So remember, if I am speaking about leukemia, the most common becomes BALL. If I am speaking about lymphoma, then the most common becomes TALL. And almost, just remember, the ALL, acute lymphoblastic leukemia, it is the most common cancer affecting children. And the peak incidence of BALL, it is at the age of around 3 years. Okay, it's around the 3 years age. Why is it so, so early? Because it is at this age that the number of precursor B cells are maximum. It is greatest, okay, very early in the life. Okay. Similarly, the peak incidence of TALL is seen in adolescence. Why? Because it is at this age that the thymus reaches the maximum size containing maximum amount of precursor T cells. That is why TALL is maximally seen in adolescence, because at that age only the thymus reaches the maximum size. Now remember, BALL and TALL, they also occur less frequently in adults of all ages. So it is not like the leukemia doesn't occur in adult, it occurs in adult, but it occurs less frequently. And remember, the prognosis in adults is far bad as compared to that which we see in children. Let us look at the genetic alterations that we see. Now, most of the TALLs, they have mutations in the notch. 50 to 70% cases have mutations in the notch, and rare cases might be associated with mutations in FGFR1, which is also associated with eosinophilia. Similarly, BALLs, they have maximum mutations involving PAX5, ETV6, RUNX1, and all of these genes are required for normal differentiation of the B cells. Now, a translocation 1221 involving RUNX1 and ETV6 is present in 25% cases of the BALL. Now remember, these mutations, they promote maturation arrest. That means from the precursor stage, they will not be able to mature further. Okay, so they cause maturation arrest and there's an increased self-renewal. So what is going to happen? This is going to lead to increased amount of lymphoblast, where either in the blood or in the lymph node. So if increased lymphoblast occurs in the blood, what is the term we will use? Yes, we are going to use the term, very good, leukemia. And if increased amount of lymphoblast is affecting the lymph node, which term we are going to use?
Lymphoma.
Lymphoma. Very good. So you have understood this point very clearly. Okay. Now, very importantly, that in any kind of ALL, around 90% of all the ALLs, they have some or the other changes in the chromosome. Most important is the numerical changes. They have hyperdiploidy and hypodiploidy. Now, why are we reading about this hypo and hyperdiploidy? Because if you identify these ploidies, okay, they are of prognostic significance. Okay, I will show you in the end how they affect the prognosis. Okay. Plus, they contain a variety of balanced chromosomal translocations. Now, very important, as I told you, they are important for prognostic purpose, as hyperdiploidy and hypodiploidy are seen only in BALL. So they are, and they are associated with a better prognosis. So hyperdiploidy is associated with a better prognosis, whereas hypodiploidy is associated with a worse prognosis. Hypodiploidy is associated with a worse prognosis. Okay. Now, very important thing is that if you see, now if you just look at the bone marrow slide, or if you look at the peripheral blood smear, whether you see a BMA, or you go for a peripheral blood smear, or you take a biopsy from the lymph node, in any case, you cannot differentiate between BALL and TLL. Morphologically, both of them, they are identical. They are looking like a lymphoblast. Yet, cytologically, it is impossible to differentiate. Yet, the WHO has given down certain guidelines, okay, which can help us in differentiating. But practically, it is of no use. They say that BALL versus TALL. Now, TALL, they have a relatively more uniform monotonous population as compared to BALL. And in case of TALL, you have certain convoluted nucleus, whereas in BALL, the cells are more round, okay, and they have a more fine open chromatin and multiple nucleoli as compared to TALL. So I'm now going to show you a slide. This is a slide of BALL. If you see cytologically, okay, remember these cells, if you see, they have more rounded nucleus, and they have a more speckled chromatin, as you can see, more open chromatin, and more prominent nucleoli can be visible in case of BALL. Whereas in case of TALL, if you see, they are more monotonous. They are more monotonous. The nuclear chromatin is more coarse as compared to BALL, and the nuclear size and shape, it varies little bit more. So there is anisokaryosis, and they have classical nuclear convolutions. Okay, nuclear convolutions are there. Now, all these points that I have discussed, they are just for theoretical purpose. Usually you cannot differentiate. And one very important point of difference is also that at the TALL, if you see, okay, they have a much higher mitotic activity. If you see, there are multiple mitotic figures over here, if you can appreciate, as compared to the BALL. So morphology wise, I am just speaking in terms of both TALL plus BALL. I have discussed the basic differences, but apart from the basic difference, I just want to tell you, if you carry out a bone marrow examination, in case of leukemia, you are going to see that the marrow is hypercellular. Okay, and they are packed with lymphoblast. Which replaces the normal marrow elements. Okay, now mediastinal thymic masses, as I told you, 50 to 70% of the thymic masses, they are of TALL origin. Okay, and as I told you that the TALLs are the one which involves the lymph node and your secondary lymphoid organs much more than BALL. So you are much more likely to get a lymphadenopathy and splenomegaly with a TALL as compared to a BALL. I have discussed why. Now, very important, the tumor cells, they are like any other lymphoblast. Okay, so what are the features of a lymphoblast? They have a very high NC ratio. They have a scant agranular basophilic cytoplasm. Nucleus is larger as compared to those of a small lymphocyte. So we have to compare a lymphoblast from a small lymphocyte. It is very important to differentiate. And sometimes nucleoli might be visible. They may have a high mitotic rate, convolution of the nucleus might be there, and you might see a lot of intermittent macrophages, because whenever the rate of proliferation is more, the rate of death of the cells is also high. So the need for clearing the dead debris also becomes more. So the amount of macrophages also increases. So let me just show you this particular image. So you tell me what is this and what is this and what is the difference. So this is basically a lymphoblast, okay? And this is a normal small lymphocyte in a peripheral blood. So let us see the point of difference between the two. Absolutely, the lymphoblast is larger in size as compared to a small lymphocyte. And you can see, how do you see the size of a small lymphocyte? The nucleus of which is absolutely, according to the size of a normal RBC. That is how we see the size of a small lymphocyte. If you look at the nuclear chromatin, if you now remember, both of them are having a high NC ratio. So you will say, sir, both of them are having a high NC ratio, then how do we differentiate? So one is the size. Lymphoblast, usually they are larger. Small lymphocytes are smaller in size. Second thing is that the nuclear chromatin, the chromatin is far more open, if you can appreciate over here, whereas the chromatin is far more coarser in case of small lymphocyte. Other thing, if you are going to see, there are certain nucleoli that is visible, 0 to 1 nucleoli. 0 to 1 nucleoli is seen, but over here, no nucleoli is seen. No nucleoli is seen. So it is imperative that you differentiate a lymphoblast from a small lymphocyte. Okay. So this is how you differentiate the features. Okay. Now, one other thing is that we also have to differentiate the blast of ALL, that is a lymphoblast, from an AML. Now, in the class of acute myeloid leukemia, I have already discussed the points of differentiation, which I'm going to repeat now. So if we compare a myeloblast from a lymphoblast, if you see, a myeloblast is much larger in size as compared to a lymphoblast, which is smaller in size. Now, they have a pretty good amount of cytoplasm. Myeloblasts have a good amount of cytoplasm, if you see, and which is also granular in nature, if you can see, the cytoplasm has multiple granules, whereas over here the cytoplasm is scanty and they are agranular. Also, overall, they might be present only in myeloblast, but they are never seen in lymphoblast. Okay, the nuclear chromatin of myeloblast, they are far more open as compared to a lymphoblast. Okay, although lymphoblast has an open chromatin, but the myeloblast have a much more open chromatin compared to a lymphoblast. But the nuclear chromatin, in comparison to myeloblast, is far more coarse. Now, nucleoli is far more visible. Around 2 to 5 nucleoli is visible, as we can see over here, but whereas in case of lymphoblast, only 0 to 1 nucleoli is seen. One other point of difference is histochemistry. Under histochemistry, if you will appreciate, they are myeloperoxidase positive, whereas the lymphoblast, if you are going to see, they are positive for PAS. Okay, they have block-like positivity for PAS. I'm going to show you all these features. So we have to differentiate the lymphoblast from a myeloblast. Okay, and we also have to differentiate the same from the small lymphocytes. So I have discussed the points of difference for the same, and also the histochemical staining I have discussed to differentiate lymphoblast from a myeloblast. Now let us move ahead. Now this diagram, if you see, this is a diagram taken from a lymph node. Okay, so probably this is what? This is a lymphoma. This is a lymphoma that we are speaking about, because it is involving the lymph node. Now the first thing that you have to understand, that how they have, how can we say that this is some kind of neoplasm involving the lymph node? Because normally if you see a lymph node, you will have primordial follicles like this. Yes or no? And sometimes you find inside there might be an active germinal center also, but over here no such arrangement is seen. So this is actually called as an effacement. It's called as an effacement of architecture. Effacement of architecture is seen over here. Okay, so this is how we can say that some neoplasm has affected the lymph node. This is typically how a lymphoma is affecting a lymph node. Let us see over here. Now this is again under the high power view. This is a slide of TALL. As I told you, the points of difference is the nucleus is showing convolutions, and the size and shape of the nucleus is far more variable as compared to BALL. So there is anisokaryosis. Okay, and if you can appreciate, there are nucleus which is showing convolutions. Okay, classically over here, and very importantly, there are lots of mitotic figures, if you can appreciate. Okay, very high rate of mitosis is there under TALL. If you compare it, and yes, the population over here is far more uniform and they are monotonous compared to a BALL. Over here, if you see, the nuclear pleomorphism is far more, okay, and they have a more round morphology with a more open chromatin, okay, and they have a lesser mitotic rate compared to the T lymphoblast, okay. Okay. Now, this is very important. This is what you can expect in your exam slide. Okay, you will be given a peripheral blood smear. Okay, and can you appreciate over here what are these cells? What are all these cells? Yes.
Class.
Very good. They are the lymphoblast. Now, why am I saying is that it has a lymphoblast and not a myeloblast? Yes. Why we are saying that? Because if you see,
Coarse chromatin.
they have a high NC ratio. Yes. They have a coarse chromatin. Okay. Along with that, they have a scanty cytoplasm, scanty A granular cytoplasm, scanty A granular. Also, the nucleoli is inconspicuous, not that much present. Nucleoli is inconspicuous. Okay, so that is why we are calling it as this. And look, compare it with the size of a normal RBC. It is much, much bigger than the size of a normal RBC. So this is not a small lymphocyte also. Okay, clear? Okay. Now, this is another histochemical stain that I told you. This is the histochemical stain. So in the lecture on AML, I had shown you one slide showing MPO positivity, myeloperoxidase positivity that is seen in cells of myeloid lineage, okay, in AML. Whereas in case of ALL, the histochemical stain is PAS and they have a typical block-like positivity. Can you see they are block-like positive, okay? This is the typical block-like positivity of PAS in case of your ALL. Okay, let us now discuss the immunohistochemistry. So if you are going a immunohistochemistry, that there are certain stains which is going to help confirm the lymphoblastic nature. Lymphoblastic nature. That means the precursor cell nature. Okay, so precursor cell nature is going to be confirmed by a very important immunostain, that is TDT. It is present in more than 95% cases of precursor B and T lymphoblast. There is another marker which is not as sensitive and specific, but which is also present in the precursor state, that is your CD99. Remember that CD99, it is a less specific marker of lymphoblastic neoplasm, and more importantly, they are positive in Ewing sarcoma or PNET, peripheral primitive neuroectodermal tumor. Now, if we have to choose certain specific markers, now go through the lecture on your normal hematopoiesis or basics of normal hematopoiesis. I have discussed in details all the markers for all the different kinds of cells. Specifically, if you have to choose for giving a diagnosis of BALL, TDT will be positive in all kinds of lymphoblastic lymphoma. CD99 will also be positive, but something which will become very specific for BLL is CD19 and PAX5. These are present in the most precursor form. Now, if this precursor form becomes little bit more mature, they will start to express other markers like CD10, CD20. Okay, these are other markers that they are going to also start to express. So what are the markers which we are going to use for this? TDT first, CD99 second, then CD19, PAX5, CD10, CD20 for BALL. For TALL, the markers that we use mainly is TDT and CD7. That is the best marker. Other markers that we use in the precursor stage, in the early stages, CD1, 2, 5, 7 will come out to be positive. And in the later stage, means in the later stage of the precursor stage only, CD3, 4, and 8 will come out to be positive in the later stages. Okay, I hope this marker system is clear for you all. This is just one example. So the TDT staining, it has confirmed the lymphoblastic nature of the tumor, whereas the CD3 has confirmed the T cell origin of the tumor. Now, is it clear to everyone? If, for example, this marker was CD19 positive, in that case, we labeled it as BALL. Okay, why we are calling it as ALL? Because they are TDT positive. Okay, and then we just find the lineage. So let us look at the clinical features. Now, it is very simple. Now, if there is a bone marrow over here, if you can appreciate the bone marrow, and if there is rapidly proliferating tumor cells, then what are they doing? What are they trying to do? They are actually occupying the space which was once occupied by the normal cells. Yes or no? So what is going to happen? All the cell line, there will be cytopenia. There will be decreased space for RBC. So there will be decreased hemoglobin leading to anemia. There will be decreased space for granulocytes leading to decreased amount neutropenia leading to a lot of infections, and there will be decreased space for platelet production. So there will be thrombocytopenia. So typically the patient presents with a pancytopenia and one or two other symptoms arising from that pancytopenia. Now, suppose if it is a TALL, if there is a lymphoma patient. Now, in case of lymphoma, what will happen? Because these tumors are going to proliferate in the extramedullary spaces or extramedullary lymphoid tissues. So there will be hepatosplenomegaly. There will be generalized lymphadenopathy. So in case of lymphoma, this patient will present with lymphadenopathy. Also, one important thing, in any kind of leukemia lymphoma, when there is a bone marrow involvement, there is a characteristic bony pain or bony tenderness. Okay. Now, other things like CNS manifestations like headache, vomiting, nerve palsies are also very much common in ALL. Now, one very important thing is that pediatric ALL has one of the most, is the greatest success story in oncology, because with aggressive chemotherapy, about 95% children in ALL will go in complete remission and 75 to 85% will be completely cured. Okay. Whereas if ALL occurs in adults, only 35 to 40% of adults are cured. So the prognosis is more guarded in case of adults. Looking at the last important slide over here, if you see, now, this is very, very important, the prognosis of ALL. So what are some of the favorable features and what are some of the unfavorable features of ALL? So if ALL occurs in the age group 1 to 10 years, it is having a good prognosis, but less than 1 year, more than 10 years is very unfavorable. Female sex has a favorable prognosis compared to a male sex. A total count less than 1 lakh is having a favorable prognosis. Okay, this will be lower count. This will be higher count. Okay, so a count more than 1 lakh is having an unfavorable prognosis. If there is presence of CNS disease, it is indicating a bad prognosis. Absence of CNS disease is a good prognosis. As I told you, hyperdiploidy is a good prognosis. Hypodiploidy is a bad prognosis. Now, translocation 1221, trisomies 4710, all of these are favorable prognosis. Okay, whereas if BCR-ABL1 gene fusion is present, yes, you are right to hear BCR-ABL, which was common in CML, it is also seen in ALL. And if it is present, it portends a poor prognosis. KMT2A gene rearrangement also portends a poor prognosis. The time taken for remission, if it is early, it is favorable. If more than 1 month is required, then it becomes unfavorable. And relapse is far more common. If relapse is there, it becomes unfavorable. And if relapse is not there, it becomes a favorable prognosis. So with this, we have completed acute lymphoblastic leukemia. Yes. Why in adults the prognosis is so low compared to children? Is there any factor that helps? See, one thing that is there, we don't know why it is. This is something that has been observed. Probably one of the reasons why it is that children are better able to maybe tolerate the chemoradiotherapy that they receive as compared to the adults. Okay, this is one of the reasons, but not a complete reason. Is it understood?
Yes, sir.
Okay. Any doubts with regard to acute lymphoblastic leukemia? So I have discussed the prognosis, the clinical features, the immunohistochemistry, then the morphological feature in the peripheral blood, then the lymph node, how BLL, TLL are different, what is the lymph node presentation, how we differentiate it from a myeloblast, how we differentiate it from a small lymphocyte. Okay, then we had read about your basic features of ALL, okay, basic introduction features, and then we had also discussed the basic classification of ALL and other kind of lymphomas. Okay, so with this we have completed acute lymphoblastic leukemia. Any doubts with regard to ALL? Anyone? Yes. Okay,
Sir.
if you do not have any, yes, tell me.
So can you repeat immunohistochemistry once? Like TDT positive means that what?
See, there are certain markers which are expressed by the precursor cells. Okay. So basically, if the tumor is expressing TDT, that is basically pointing towards the precursor cell nature of the lesion. That is the immature nature of the lesion. That is what is the importance of TDT. The TDT is confirming the lymphoblastic nature. So first you confirm that, okay, it is a tumor arising from the precursor cell. After that, you can give the panel of CD19, you can give PAX5, you can give CD7, you can give CD3. So if the tumor after the TDT positivity, for example, came out positive for CD19, that means it is a BALL. Now, for example, if it came out positive for CD3, that means it is a TALL. Understood now? So TDT as well as CD99, they are just there to confirm the precursor nature of the lesion. Okay, it is because, as I told you, whenever a lymphocyte is maturing, it goes through several stages. Now, the most precursor stage is the stage from which your lymphoblastic leukemia arises. And to confirm the lymphoblastic nature or the precursor nature, we have to do TDT and CD99. Now, is it clear to everyone?